Welcome. I'm Leanne Meyer, and this is Once a Nurse, Always a Nurse. I want to welcome you back again. Thank you so much for all of you who have been contacting me through my website, onceanurse.com, through LinkedIn, Facebook, all the many, many different ways you get a hold of me. I cannot tell you how much I appreciate being able to hear what's going on for you right now, especially as I know things are changing moment by moment. So thank you, thank you, thank you. If you're looking for this podcast, we are on YouTube as Once a Nurse with Leanne Meyer, and on Spotify and some of the other ones as Once a Nurse, the original. So a little bit of challenge to find me. You can also find my old podcasts that were with voiceamerica.com, and those are at Once a Nurse, Always a Nurse, and it will take you right to those. And there's about 150 podcasts there. So today is a very special day. I am just really thrilled to be able to have my guest here today, and I'd like to tell you just a little bit about him. He is Dr. Ernest Grant. He is currently the Vice Dean of Diversity, Equity, Inclusion, and Belonging at the Duke University School of Nursing. He is also the immediate past president of the American Nurses Association. I think a lot of you out there will know that. And he, I kind of like this one. He is the first man in 127 years of existence of the ANA to be elected the office of president. And I think that's just a wonderful statement about who he is and what brought him to that place. So I'd like to welcome Dr. Grant at this point. Please come in and we'll talk a little bit more about all of your wonderful accomplishments as we're able to discuss them.
Well, thank you very much, Leanne. Be here.
I'm always happy to have you. You are a very positive influence, and I like your perspective on a lot of things. So thank you for being with us. So we have a lot of things to talk about. I was thinking the last time that you were on was, I believe, February of 2021. Mm-hmm. And that's like 3 years ago. So we have had a lot happen in the meantime. I know that you have like 30 years of nursing experience, and you have apparently most of that was in burn care and
yes.
fire safety. Is that correct?
Yes.
And that you are an adjunct for the School of Nursing for UNC Chapel Hill. My niece went to Chapel Hill, so that's kind of a place of connection for me. And you work with undergraduates and graduate nursing students in the classroom and clinical settings. So I want to talk about that in a minute, but tell me first about that nursing experience with burns and burn units. How did you get into that?
Well, my career in burns actually started sort of as I really won't say an accident, but I'm originally, I don't believe in that as well. I think it was divine intervention, actually. I am originally from the mountains of North Carolina, the Asheville area, and I moved to the Durham Chapel Hill area to complete my baccalaureate degree. Mm-hmm. And the particular burn center that I worked at, it's officially named the North Carolina JC. And if your audience is familiar with the JCs, the North Carolina JC, yes, Junior Chamber of Commerce, yes. Okay. So the burn center is one of their state projects. And I happen to have been a member of my local chapter in the mountains. And so when I moved to this area, I thought, well, I'll work there for a couple of years until I finish my degree and then go back to the mountains. Well, lo and behold, 36 years later, I retired from there. So, but it was, and still is, I consider it still one of the most rewarding experience I had as a nurse. You really, as students, everything you learn in nursing school, you apply in that setting. You really get to help your fellow man when they are really at their most vulnerable. I still have contacts with patients that I took care of 30 some odd years ago, where it's just like family. And so they keep me abreast of as grown up, if they were a kid or they were an adult, they're now grandparents, or this is happening in their lives, or you've got to come to this wedding, or this family reunion, and et cetera. So it really is very, very rewarding just to know that you were in their lives for just that particular vulnerable moment to help them guide through that that crisis.
Yeah.
But that friendship has lasted all these years.
I was going to ask you, I know 6 months ago or 9 months ago, when you were just about out, not quite left the ANA,
Mm-hmm.
I asked you if you knew which direction you were going to go. And I know you had many, many, many offers to go in many directions, but now I understand why the North Carolina hills were
Mm-hmm.
calling.
Yes.
So tell me of, as you're working with the School of Nursing and
Mm-hmm.
those nursing students, what do you see that's different in them? What do you see that you think is going to be critical for nurses to have going forward into their future of nursing?
Mm-hmm. Well, it's really great. The students that I work with at Duke. Now, you did mention in the intro that I'm adjunct faculty at UNC, full-time faculty at Duke. So I'm sort of one of those
Can't
by
get
law.
enough.
Yeah. But I do work with students, at Duke as well. And one of the things that I'm, obviously at Duke, our program is accelerated program. It's an APSN program dealing with students who come in with already lived experience. They tend to be perhaps a little older students. I mean, some are in their their early 20s or so, but they started another career and then opted to come into nursing. And that is very challenging because of the either the short or midterm lived experience that they have. They bring that with them.
Yes.
And so
Yes.
it's more of a challenge to sort of mold them, if you will, into what we would consider maybe the traditional nursing mode. And it's not what we really want to do at Duke. What we're really trying to do, our program focuses on producing what we call it nurse-led models of care. In other words, you're getting the traditional nurses training, but we're also grooming you to be leaders, to ask questions, those questions, and how can we make this better? How can the patient have better access to to care, or what in the community can we change that will improve healthcare all the way around?
Yeah.
So meeting those challenges, and sometimes they really astound me with some of the ideas and concepts and things that they come up with. And of course, they're embracing innovation and modern technology to advance that as well. And I'm not that much of a technocrat, but when I hear their ideas and things that they're wanting to do, I'm just floored by it, because it's the possibilities are endless. And the fact that if it is someone who comes from an IT background but they want to go into nursing, wow, that's really like a mind-blowing experience, how they can incorporate what they'd like to do in the community, or or within their work environment, and embrace technology along with that to make things more efficient, more convenient, and just the possibilities are endless.
I'm thrilled to hear this for two reasons. My last job before doing the podcast was working with nurses returning to nursing after periods of 5 to 28 years away from
Mm-hmm.
nursing. That was such a fulfilling thing for me to do. I was so amazed at the passion and the confidence, and not confidence when they came in, but confidence
Mm-hmm.
when they
I
left.
agree. Mm-hmm.
And like you, I still can
Mm-hmm.
keep connected to many of those nurses, which just absolutely blows me away.
Yeah.
And then the second thing is, I'm working with Nurses Transforming Healthcare.
Mm-hmm.
And our platform with that is we see nurses being a fantastic and central aspect of
Mm-hmm.
healthcare in the future, because
Mm-hmm.
we see nurses as being able to fill that role of uh, uh, working with people to keep people
Mhm.
healthy and to
Mhm.
prevent illness. My original goal about 4 years ago when we first started talking about this was to have a nurse-led clinic on every corner
Mhm.
where there's now a McDonald's. I think we should just
Yes.
take over the McDonald's,
Yes.
nurse-led clinics, eventually nurse-led hospitals, which of
Mhm.
course in years gone by, that was often what happened was nurses were
Mhm.
leading or even starting
Mhm.
hospitals in various different places, including your area of the country.
Mhm.
So, so I know that you have been recognized by Modern Health Magazine as one of the 50 influential clinical executives of healthcare
Mhm.
and one of the 100 most influential people in healthcare. When you think about that, how do you see yourself fulfilling that?
Oh, that's a really tough question, but I guess that one of the ways that I see myself fulfilling that is to uh, I see myself as a transformational leader,
Mm-hmm.
and being able to embrace new ideas, new thoughts, to um, question, why can't we do it this way, or why isn't there a possibility that the old way of doing things, it's a little dated, so let's step into the 21st century
Right.
and and really embrace technology or embrace ideas and concepts. I mean, that's how change is done, right? Is
Mm-hmm.
because someone
Sure.
thought, well, is there a different way that we can do
Yeah.
this? And
Well,
it
and
turns out,
nurses are always thinking that.
oh, absolutely,
Yeah.
absolutely. And so one of the ways that we've been able to do that is to always think, what are some of the is there other ways that we can do this and still either have the same or better effect,
Outcomes.
cost efficient, and also that still involves the nurse being there to to help guide and to oversee that, if you will.
Yeah.
And so that's where I see that being that clinical executive is to inspire thought and creativity, and to have those dialogues, to sit and listen, and to maybe even play the devil's advocate, to get those
Right.
juices stirring, but playing
Yeah.
the devil's advocate and say, yeah, but what about this, or what about that,
Yes.
and how are you going to address this and that,
Yes.
so that when we do try to implement some ideas or whatever, we have thought about roadblocks and are ready to to jump over those.
One of the things that I keep hearing people say that are talking with me is they feel like, well, for one thing, there's, I think you had mentioned there's so many people that want to talk about the negatives.
Mhm.
And my producer is Tanya Abreu, and she was just talking about speaking with somebody just a few days ago about, if you want to get a place at the table or you want to be heard, you got to start speaking.
Mhm.
And so to get past those, I think in some ways we look at the roadblocks as being put in front of us.
Mhm.
But I think, like you said, looking at ourselves as leaders. And I would love, I don't know how long in the future this would happen, but I would love to see nurses take our profession back as being in charge of our
Mhm.
profession, as opposed to being under, say, the AMA or the AHA or all the other alphabet soup. Um,
Mhm.
and I would absolutely love to see nurses in charge of anything that has to do with patient management, because who
Mhm.
does patient management other than us?
You, couldn't have spoken more clear words myself. I'm a firm believer that we are at the center, and when
Mhm.
you think being the largest portion of the healthcare system, but yet, um, if I may borrow the words from Ruth Bader Ginsburg, we have knees on our necks to
Yes.
prevent us from doing what's right and what we know could be a more efficient way to do things. And I think it's part of it is, um, you could say that it's since it's a female dominated profession, that it is society's disrespect of women,
Hmm.
and is where a lot of this stems. I think as we get more men and more minorities into the profession, and we find our voice more and more, that we'll begin to see the changes that we want to envision. But I'd like to see that sped up a little bit.
Yes, a lot. Like let's really get it going.
Yeah,
Yeah.
absolutely. To think that, it's like you get it in little bits and pieces, and it's like, well, we've given you this, aren't you satisfied? We've given you that, aren't you satisfied? And it's like, no, we need to jump from the latter part of the 19th century, if you will, into the
Yes.
21st century, and we need to do it now, so that we can be the ultimate player, if you will, in the
Yeah.
game, and not only healthcare, but address the nursing profession itself. I mean, I
Right.
can't think of any other profession out there that, as you mentioned, you've got people from the AMA or from the hospital association or from other even the payers dictating what we can and cannot do. But we meet the definition of a profession, but yet we're not recognized from that perspective.
Yeah.
And we really need to begin to
I'm curious.
address
This is another of the things I've been working on and will be working on going forward. Is when I started practicing, and I've been practicing now for 50 years, I public health was like the end all and be all. If they said jump, we said how high, and I see that has really been changed, and they've been kind of had their knees cut off. And the other thing I'm noticing now is that the people that are still in public health oftentimes are not nurses, which, we essentially started that with, in your area, going into the mountains and taking care of people in their homes. And, some of those things going in urban areas, going to the tenements and, dealing with the problems that were there immediately. So that's kind of what we're seeing is, if we can, or when I really think this can happen because it seems to be an idea whose time has come, is nurses leading healthcare from the standpoint of how nurses think about healthcare. We don't tend to think about it as looking at the disease and how do we fix it. We're looking at the person and saying what all contributes to whatever it is that this person has come to me about. And then dealing with, the social determinants of health. I think, a lot of people paid lip service to that. Yeah. But I feel like if we started working with the social determinants of health with people and we could clear up what they see as the most important thing for them, we could start, cutting those off the list, getting people healthy, getting them back to work. And I didn't mean to talk that much about it.
Oh, no. But I just want, you just gave the perfect definition and example of our model of care at Duke. When we talk about nurse-led models of care, it is looking at everything within that person's environment that is either contributing to their chronic illness or that is the resources. And the example that you gave, like the old, I think of it as the old nurse midwifery model, where yes, you're taking care of the mother and the baby, but then anything else within that environment that affects the rest of the family.
Absolutely.
So it means
feeding their the other kids,
right. So
dealing with whatever happens.
There's a leaky roof, or there's I don't know, rats or cockroaches running around in the place. You use those resources to to take care of that because you knew that the varmint infestation could contribute to ill health. And so using the community resources to get rid of those and et cetera, and continue to monitor the health of that mother, that baby, or the rest of the family, or if there was lead paint, on the walls and et cetera. Those are things that, we as nurses would do. And, knowing, we're in this particular situation, what are the things that we need to arm ourselves with to help this particular family? Whereas right next door, there may be another different problem, and we still need to, address that as well. So your idea, the concept of, nurses, or nurse-led clinics on every corner, I love that idea. It's almost like,
Mhm.
when I go to the large cities and you see a Starbucks
Yeah,
every corner and one in the middle. It would be great if we had that across America to,
that would
um,
be
yeah,
fantastic. And
absolutely.
so what you're doing with encouraging nurses to be leaders and then go into those areas, have that education, have that background of advanced practice, and
Hmm.
then learning how to be able to create these clinics. And
Hmm.
what we're actually doing right now too is we're in the process in the next couple of weeks of having a number of doctors combining with NPs to
Hmm.
plan sort of a template for
Hmm.
how a collaborative clinic could look. So rather
Hmm.
than having the hierarchy of doctor, nurse,
Hmm.
whoever else, having the collaboration of whoever is there, what's their wisdom, what's their, so that you have maybe a nursing assistant who has, like you said, life experience that they're bringing into it that, maybe be the exact right thing in that particular moment when
Hmm.
the other people are saying, scratching their head and saying, I don't know what to do with this.
Hmm.
Let's take this right into, I know this is an area that you feel strongly about, so I want to spend the most of our time here, is the work that you're doing now with addressing racism, looking at equity and inclusion. And you also mentioned belonging, which I'm so
Hmm.
happy that you included that. That's not one of the words that a lot of times people use, especially uh, in a title or what it is that
Hmm.
you're doing. So tell us about that. What does that all mean in reality for you? What it is that you're doing?
Well, my role as the vice dean for diversity, equity, inclusion, and belonging at Duke is to ensure that there is equity across the whole playing field that is inclusive of faculty, that is inclusive of staff, that is inclusive of students. And Duke University itself, as well as the School of Nursing, they have put forth a renewed effort towards addressing. And when I started my position there as the interim, one of the things that I wanted to see was, are they serious about this, or are we just checking a box? And,
Yes.
and no, they're being very, very serious, which I enjoy. The tagging on the when I was appointed as the official vice dean, we did change the office to add the word belonging,
I
and it
have a
is so
feeling you had a
important
part
that
of that.
we right. It is so important that we have belonging because
Yeah.
when you find yourself in a situation where you don't see you, or you don't see where you can fit
Yes.
in, or you come to work every day, but do you do it because you love to come to work? You do it because it's a job. That to me are some of the things that we look at when we think about belonging. Do I have a voice? Am I being heard? And that's one of the things that we're in the process of putting together a survey, and we'll be asking
Mhm.
faculty, staff, and students, what does belonging mean to you? And make sure that we get some
Mhm.
ideas and begin to build around that is specific to the Duke University School of Nursing. Because obviously belonging in
Mhm.
one instance may be different, but we can certainly try to um, incorporate that, or at least have that dialogue, that people do feel that I can have a
Yeah.
say in where I may be going,
Mhm.
or if I'm coming into work, know that the work that I'm doing is valued, and
Mhm.
that my voice is being heard. That's a huge thing there, in that you do feel that you're able to play a very
Sure.
critical role in how things, how equity, if you will, may be addressed across the system.
Right. I know that North Carolina has a very diverse background. Does that
Mhm.
reflect in the classes that you're teaching and the nurses that you're working with?
Yes, it does. We are at Duke. We have, in looking at our students, we have probably about 60% of our students are from North Carolina.
Mhm.
The other from across the U.S. and actually globally.
Mm.
And we are very, very proud of that. The good thing about that is that, once they graduate, they're going to take what they've learned as,
Yes.
as nurse leaders.
Yeah.
And as they go out to different parts of the globe, it's like that ripple effect. Really,
Yes.
really great to, to have that. And they're being agents of change. And as they, promote equity, diversity, inclusion, and belonging, we're going to see that ripple effect across various areas of healthcare, be it in the acute care setting, the clinical setting, community setting, whatever. So it's really great. And of course, in our curriculum, we've just done a curriculum redesign as well, whereas there's that constant thread of DEIB in all the courses that the students are taking as well, and also in their clinical areas too. So again, there's that reinforcement, if you will, that really makes it, it seems as if it's second nature, that you're going to automatically begin to sort of think that way.
Yeah, it's really hard, I'll speak broadly for many of the people who have been in primarily white environments to even see the racism that happens, especially in hospitals, and especially, well, I'm sure with everybody, but I'm more familiar with it with nurses. Is there anything, it sounds like you're integrating this aspect within each course. So how does that look? Say if there's an incident in a classroom where somebody is speaking up and saying, whatever was said or done felt very abusive to me. I don't know what word you would have them use. How do you address those things right there and then? How do you encourage them to both hear when somebody is telling us, what you said hurt my sense of self?
Yeah, that's the key word there is getting the individual to actively listen to what the person is saying, because sometimes we automatically throw up walls, or we'll say
that.
Yeah, or it's oh, that's not what I meant, or whatever. But to hear that it may not have been what you meant in your saying, but if you continually say that, like those micro, if you will, terms like, oh, you're doing that really well for someone, like you, or, or for a male, or, it may have initially, you probably were meaning it as I dare say a compliment, but maybe as a joke or that. But the way that it was interpreted, you need to listen to what the individual who it was directed to and what they have to say, and cause you to think next time before you you say those words. And it's not like as though we're wanting trying to get people to check themselves, but in a way we are, because it is important that words matters. Words can hurt, and once they're out of your mouth, you really can't take it back. And so it's important that people begin to understand that it's that we need to govern ourselves, if you will, and put what if the shoe were on the other foot? What if that was aimed at you? Now, obviously, if you're a white person, one of the things we try to get people to understand is that you have automatically just white privilege just by being born white. And
we don't even get that. I mean, I speak for myself. I had to learn this the hard way, and I'm learning every day, because there's so much to it that you hear white privilege and you think, I have had a damn hard life and I've worked really hard to get where I am. How can you say that I have privilege?
And just to point out, like I'll use an example. Sometimes I can go into a jewelry store. I could be dressed in a suit. And a white person could follow me in who could be dressed in rags. I'm going to be followed around that jewelry store, probably asked 2 or 3 times, may I help you? Is there anything, type thing. And whereas
check your pockets.
Right. And the white person will be allowed to roam freely. And, they may be asked, may I help you? But I doubt that they're going to be followed around the jewelry store like I would be. And, so it doesn't matter that I could probably afford to buy,
Anything there.
anything there, but
Duplicates.
it's just this automatic profile that you have when you walk in, and your audience can't see, but I'm 6'6", so I understand that I'm an imposing figure, but you don't know me. You don't
Yeah.
know that I have a certain income, and or whatever else. You just automatically assume, oh,
Right.
6'6" black guy walking in here, and I gotta guard my stuff,
Yeah.
type thing. And that's what we call privilege. The mere fact that someone coming in after me or before me could walk in, and nothing is thought about, but yet when I'm constantly under scrutiny. And yes, a lot of my white colleagues will say, I don't see color. I don't. But then when I say you don't, yeah,
Are you,
you,
are you
you don't
blind?
see me, then yeah, how can
Right.
you? Yeah, how can you? Because what you're doing now is you're automatically lumping with every other 6'6" African American male, and I like the phrase that. Uh, I think it's UPS has it's what can Brown do for you today? What I'd like to say is what can you do for me today? Not
Yeah.
just every 6'6" African male, but what can you do for Ernest Grant, the 6'6" African American male? And that way you do get to see me, because you get to personalize the care that I need to have.
One of the things we wanted to talk about is nursing workforce issues, but let's use this to lead into that. And I'd like you to talk about, racism in nursing. So on a unit where not always, certainly like maybe in North Carolina, you'd have a majority of people on a unit that are people of color, of various different colors, whether it's indigenous people or, other backgrounds. But how can we find a common place to talk about without being angry or frustrated or feel like we've been put down, for anybody that's in that system to not be treated as respectfully as we would like to be? So on a unit in a hospital.
Well, there again, I think it boils down to the culture of the institution, and whether or not we say that we have policies and things in place that such things will not be tolerated, but we see just the opposite when something like that does happen. The individual may be discouraged from filling out an incident report or reporting it to HR, and things of this sort, because even if it was a colleague that was doing it, or a patient family member who was doing it, or someone another area of the facility, because we're afraid of those Press Ganey scores going down, or et cetera. And that's not you're sending mixed messages to the individual that yes, we value you on this thing, but then when it comes to reporting either verbal or physical abuse, we're going to sweep it under the rug. And so the message you're sending is one that I am not valued here.
Right.
And so administration and those that be, and the powers that be, need to be cognizant of the fact that you're creating an environment where people feel that, okay, I'll come to work, and whatever, but I'll keep my mouth shut. And that's not going to create change. You want to create change, and in order to do that, again, you need to actively listen to what people are saying is happening, and then do something about, not just listening, but also do some and report periodically. This is where we are on this. If it means forming a committee or whatever, then or setting examples. When someone does do that, and your policy says it's ground for automatic dismissal, then after a few people see that a few people were dismissed, perhaps we'll begin to mean that they mean business when we're talking this way. So those are just some of the ways in which that could be addressed in the workplace. But the main thing is doing a cultural change, and that culture starts at the top. When management themselves need to set the bar, if you will, and feel that make the employees feel that, we have an open door. You can come to talk to us, and this will not be tolerated. And and when we see that it is happening, aggressive action will be taken to
Here's the
underscore
thing. This is one of my pet peeves too.
it.
Is I'm also a Buddhist, and so I
Hmm.
tend to look at things like the organization that I worked with just before I was injured and
Hmm.
had to stop was using Quint Studer's philosophy
Hmm.
and his company to teach us to be a relational organization.
Hmm.
And so instead of doing, I forget what we used to call it, but punishment, or,
Hmm.
we're going to come down hard on you. We did a lot more of let's coach, this
Hmm.
individual that's on, especially if it's on our unit.
Hmm.
And so it's like, many times they don't get why is this such a big deal,
Hmm.
because they don't understand how it creates a problem.
Hmm.
So if we can come like, let's talk about this
Hmm.
as adults, as professionals, because when we come down as that, parent child, we're going to come down really
Hmm.
hard on you, is not the first step, but it's some managers thinks that's the easiest step, is I'm just going to clobber
Hmm.
you. And so many people, especially people in this country, just tend to push back immediately and say,
Hmm.
no, you're not going to treat me that way.
Hmm.
So we have to somehow um, get connected to them. And
Right. Right.
that's where I have a problem with managers being promoted simply because they were the best nurse on the unit,
Hmm.
but they get no training. I
No
was,
training.
yeah,
Yes.
I was put into a management position. I got $1 an hour extra and
Hmm.
zero training at all. And so
Yeah.
I made so many mistakes
Mistakes.
that I
Hmm.
had to learn, kind of by the seat of my
Hmm.
pants. I wish that we could actually, I would like to have every nurse have training in,
Hmm.
understanding personalities,
Hmm.
understanding conflict communication.
Hmm.
We deal with conflict at every moment of every day. If
Hmm.
anybody needs to have those skills and those tools, it has to
Absolutely.
be nurses right at the front line.
Absolutely. You're talking about one of the things that I would have conversations when I was president of ANA. When I would have conversations with chief nursing officers, I would tell them that one, you need to set up like little miniature leadership academies, if you will, within your organization. Identify, either potential nurse leaders
Mhm.
and uh, invite them in, periodically for meetings, or send them to leadership, training opportunities. Is one of the best investments that you can make, because one, it builds loyalty. Two, it helps with succession planning. When positions open, you've got people that can easily move into that already knows the
Mhm.
philosophy and mission vision of the organization. So you really have that. And chances are the individual is going to stick around because they see that you are making that investment in them.
Mhm.
uh, they want to be as rewarding to the organization as the organization is being to them.
Yeah.
So yes, establishing those those leadership academies. When I was president of the North Carolina Nurses Association, that's one of the things we did, was to establish a leadership academy program. And I'm say that here, these many years later, that is still going on, and they have on average about 20 nurse leaders a year that goes through that, where these are nurses who are identified by chief nursing officers at hospitals across the state. They have to fill out an application, and to be, it's almost like winning the Oscars. But and it's
Or a
an
daisy.
18-month, right? It's an 18-month program that they there are things that they have to do, and they have to agree to do that, and the chief nursing officer has to agree to give those individuals time off in order to participate in these endeavors. And it's not just management, but it's also looking at policy. They will be writing letters, or going to the state house, or in some cases they've even gone up to Washington D.C. as well, to meet with some of our senators and representatives. But it gives them the full effect of things, which when they finish, they they get this wonderful certificate that yes, they have completed the North Carolina Nurses Association Leadership Academy, but it's such a value that and it really does help the organization. And these nurses have moved on up into leadership positions, and it's just making the organization that much better.
Yeah, and I would love to see that happen in every department, whether it's
Hmm.
housekeeping, linen,
Hmm.
nutrition, every single
Absolutely.
house. And I had the fortune to work in an organization that had that mindset.
Hmm.
And it was wonderful. And, so many times I talk to nurses who say they have no idea what a well-oiled
Hmm.
or functional
Hmm.
organization would be like. And so that kind of brings us into where we are now. All of those things that you're talking about cost money. And if
Hmm.
they can't see the value of a nurse, how do they see the value of, you know, um, um, promoting them and supporting them to not just get into another position where they can make more money, but that they can actually do more. So that brings us to the workforce issues that we have right now. In order to do those things, you have to have enough nurses that you can
Hmm.
pull nurses off of a unit in
Hmm.
order to be able to take that kind of training. So talk to me about that.
Well, the thing there is one of the things that I've encouraged chief nursing officers to do is when nurses are leaving, they need to make sure that they have exit interviews with them and find out, what's going on. Why are you leaving? Why is maybe one or two particular units have such a high vacancy rate, or is it, or it's a rarity now, but a unit where be a waiting list of people wanting to, transfer to that unit. But they again, it's all about actively listening and trying to figure out, what's going on in that culture of that particular unit that we have such a significant shortage, or people do not want to come to work, or is it about the organization as a whole? What are some
Mhm.
of the things that maybe the organization may be doing that the people are choosing to vote with their feet, so to speak? And if part of that, I think, is it is communications. I think if management would have town halls, I think it's important that they let the nurses and other members of the healthcare team know we're working on getting more staff. We're working on doing this and this and this. And do you have any ideas or things that maybe that we hadn't thought about? Because they may be thinking about it from the 6,000 foot purview,
Yeah.
whereas there could be an idea floating around with a staff nurse or whatever, such as well, maybe job sharing. Inviting back some people who retired, and maybe they
Yes.
share a position. One comes in and work instead of doing 12-hour shifts, they do 8-hour shifts, but they come in at a critical time when the unit is going to be busiest. So one comes in at to 12, another one comes in from 12 to 4 or whatever, in order to get the unit over that critical crunch. Is a great way to look at that, and they can serve as backup, or to help, maybe not necessarily take a patient assignment, but they can certainly help get a lot of things done on the unit that are missed because they're having to answer so many call bells and
Yeah.
things of this sort.
Well, and working solidly for 12 hours with no
Hmm.
time, you'd think in that time period you have downtime to be able to do
Hmm.
charting and do some of the other things, but you don't,
Right.
because you just keep filling them with all needs that are there.
Yes. Hmm.
I know Kathleen Bartholomew has talked with you a few different times. She's a
Hmm.
colleague of mine with Nurses
Yes.
Transforming Healthcare. And she has, proposed, what about 10-hour shifts,
Hmm.
and have the nurse work 8 hours, and those last 2 hours could be used to catch up with whatever it
What
was that
needs to be done.
she didn't get done before, or
Hmm.
be able to be the that layover, during that time period that you're
Hmm.
doing a new shift, where
Hmm.
if she doesn't have to do that kind of um, cleanup sort of thing, she could pitch in and help
Right.
them get started, so
Absolutely.
that you don't fall behind, and then then you're in a pinch. I'm hearing that they're starting to think more about hours where people could set their own schedules. So maybe they
Hmm.
would come in for 4 hours. So that
Hmm.
that nurse that has children, that she's got to
Yes.
see them off at the bus and she's got to be home to see
Yeah.
them back on
Hmm.
when they get back. So
Yeah.
there's so many different things that, just as you're talking, my mind just kind of went in 60.
Yeah, well, there is places where the gig economy, if you will,
Mm-hmm,
is working well, and for for some nurses, and
mm-hmm,
as you say, the perfect example. If I'm a single parent and I know that I need to be home for my kid when they're getting out of school, so yes, I'll look and see on the job board if there's a job from 8 to 4, then yes,
mm-hmm,
I'm going to take it, and um, with the assurance that I know that I can be home in time for when my kid gets off the bus,
mm-hmm.
and and be there to promote a safe home environment for my kid, or spend some time with my kid. And that seems to be working well. I think organizations do need to look at a variety of ways in which they
Mm-hmm.
can meet the needs of today's nurses.
Yeah,
um, and and again, listening to what suggestions they may have, because again, there could be some things that they haven't considered, that a nurse or someone else in the healthcare team may have a brilliant idea that someone hadn't really
that's
thought about before. And they
right.
have to be willing to trial it. It doesn't mean that just because you hear it and you think, oh well, that's the craziest thing I've ever heard of. you know Give it a try. You never know. The worst that can happen is that you go back, or it turns out it could be one of the best ideas that
Mhm.
could happen, and it serves as a retention tool to
Yeah.
keep that those people there.
Well, and the other thing is, you mentioned before that, people feel like nothing is happening. And as a bedside nurse for many, many years, um, there was the sense of you put forth, this is what needs to happen.
Hmm.
So I'm a
Hmm.
nurse, I got this brilliant idea,
Hmm.
and I give it to my manager who gives it to, the
Hmm.
BNO or whoever, and it goes up the line. But we never, at the bedside, hear back what
Hmm.
happened with that.
Hmm.
But
Yeah.
because I worked in human resources, I got to see what happens with an idea as it goes through
Hmm.
its
Yeah.
processes.
Hmm.
And oftentimes it isn't as easy as you think. Well, I
Hmm.
told them they need to do this and they should be starting it
Hmm.
tomorrow.
Hmm. Yeah.
To really understand the dynamics of, if we do this, what do we take away? And,
Yeah.
all of the different things. Do you see a time in the future when our hospitals will not be so um, what do I want to say, obsessively run as a business with the volume of income being apparently the most important thing?
Hmm. um I, I think that day is coming. I don't know when, but well, actually, it is pretty much right around the corner. But I um, I think though, if hospitals don't make adjustments
Mhm.
now, um, yeah, there's going to be hospitals as we know it are not going to be around much longer.
Yeah,
I think just the healthcare cost in general, and of course,
right.
they're always claiming that, oh, we have high overhead and et cetera, and where do we cut? Well, we start cutting the nursing workforce because they're
Right.
the largest workforce,
Yeah.
and unfortunately, we as nurses, we sit back and allow that to happen, and even though we call up and say we need extra help, and
Mhm.
we don't have anyone to send you, so what do? We double up and continue to take on those patients, to fill that other position that needed to be filled, instead of saying need help now, and can you look somewhere else to perhaps cut the budget, as opposed to taking it out of taking away from nursing. I've always said that the probably the chief financial officer needs to spend time shadowing with a nurse for not just a few, but maybe 10 days, and find out what it's like to not be able to go to the bathroom for 12 hours, to not be able to have a decent meal, to actually be in the rooms while doing dressing changes, or
Mhm.
giving a bath, or running a patient down to radiology, or wherever else that they may need to go. Maybe they would have a better understanding, instead of just looking at numbers
Right.
and thinking of us as commodities that can be
Yeah.
moved from here to there.
Widgets. And all the
Yeah,
widgets are the same. If you have an
right,
RN behind your
right.
name, you're all the same.
Yeah, that's it. And
Yeah.
but a nurse is not a nurse is not a nurse, and they
Uh,
need to understand that.
I've been
Uh,
working on that one for a while.
yes, we have.
Yeah. Um, the question I was just going to ask went right out of my brain. Um, we're coming to the end here, and I'd like you to be able to address anything we haven't talked about that you especially want to make sure that we do address.
I think the biggest thing is, where are we going to go? Where's nursing going to go in the future?
Mm-hmm.
This is our chance right
Yes.
now, as we are seeing, and probably our last chance, actually, as a result of the pandemic and everything else. One of the things we really need to do, though, is to get the public on our side. If we want to have transformational change, we've got to get the public endorsing the change that we want to see, because the way we do that is to get them to see that it means better patient outcomes, it means better patient care, and et cetera, so that there won't be the constant put my light on and for pain medicine, and 45 minutes later it's being answered. But one of the problems we have is that the public doesn't understand what it is that we as nurses do.
That's
Really
it.
do. They
That's it.
know that you have RN behind your name. They know that you work at the acute care facility or community health or something like that, but they don't know what physically a nurse does. Um, very few people in the public truly understand that. So we got to do a better job at promoting who we are and what we do, getting the public's help behind that, because that's going to be the big driver of change. When you look at the policymakers, the payers, the regulatory agencies, the accrediting agencies, and things like that, that's what they're going to really pay more attention to.
Right.
Is if the public say, we demand that there be enough nurses to cover this particular unit or this particular area, or things of that
And
sort.
the nurses need to decide what that has to be,
Right,
not just even
absolutely.
a number, but
Mhm.
What is the ability, the knowledge, the experience,
Right,
the
absolutely. You
confidence
got to
that
take
each
all
one
that
of
into
those nurses,
consideration.
as
Mhm.
opposed to what is the acuity of the patients that we
Right,
have. And so often that's just not taken into
right,
consideration.
right.
Um, one of you talked about, the public understanding what we do. Truly, it seems like unless somebody comes into the hospital for a period of time,
Mhm.
that's the only time they really see. I was an OB
Right.
nurse, a labor and delivery nurse, and I can't tell you how many times fathers would look at me and say, "What does the doctor do?"
Mhm.
Because what my job was to get the doctor there with 5 minutes to catch the
Mhm.
baby
You
and
have to have the
leave.
baby. Yes.
And
Mhm.
they loved me because I was able to oftentimes
Mhm.
do that, and
Mhm.
they could get paid, but they didn't
Mhm.
actually have to
You
sit
have to
there for
stake
long
around.
periods of
Yeah.
time. But I think if we have doctors who don't understand what nurses do,
Mhm.
and that came up a lot during the
Mhm.
pandemic, where I had doctors coming forward. I had one doctor that told me that he actually started out as a nurse and he became a doctor because he told me I didn't have the courage to be a nurse.
Mhm.
And that really
Wow.
surprised me. And another
That's
doctor who said, if the nurses don't show up, we might as well not either because nothing's going to get
right.
done. So you
True.
can write all the orders you want, but if there's
Mhm.
nobody that knows
Mhm.
how to uh, organize that from
Mhm.
an order to an actual event, whether that's
Mhm.
getting it to the different departments it needs to be, or actually having the time and energy to be able to carry that out. So of course, we're on the same page in so many ways.
Yep.
Um,
One of my favorite sayings is, "There's no health or healthcare without nurses,"
yes,
and that's
yeah.
certainly true.
I don't know how long you've been saying it, but I've been saying it for a lot of years that without nurses, there is no healthcare.
Mhm.
So we need to take more responsibility for it. One thing that would be nice, if you know anybody in Hollywood or anybody who's making, TV shows, they
Mhm.
have all these, fascinating
Mhm.
healthcare shows, but
Mhm.
the doctors do what the nurses actually do.
Mhm.
So it's
Yes.
like, there's no way in hell you've
Mhm.
got a doctor walking somebody down the hall.
Mhm. Yes.
That's just not what they do.
Yeah.
Uh, but I think we need to have shows that show exactly the amount of how we are making decision making,
Mhm.
how we have to balance things of what am I actually going to put my time to, all of those things.
Mhm.
And we have to train nurses to know how to do that on the fly.
Absolutely.
So,
Absolutely.
and that's amazing. We're coming to the end of our time, and I'm so sorry because I'm so enjoying this.
Well, you just have to have me back again. We'll do part
Yes, I
two.
think we have to do that.
Well,
So
actually, this is part
it
three
is
then,
part
because
two. We'll do part three
yes,
maybe in the spring. I don't
yes.
know if I've mentioned to you before, but one of the things that my producer is Tanya Abreu,
Hmm.
and she and I and a research scientist by the name of Dr. Alba Rodriguez have been working to support nurses through Power Up Nursing. And in April 21st through the 26th, we're
Hmm.
going to be doing a cruise leaving from Fort Lauderdale
Hmm.
for 6 nights and 5 days. And my secret hope, we're three things that we want to talk about is self-care, because we know nurses are
Hmm.
terrible with that. Career care, because nurses are interested in how do I utilize my knowledge and my experience beyond the bedside if I get
Hmm.
to that point where I can't stay there anymore. And the third thing is transforming healthcare. But my secret dream is that we could get a lot of different people from all different levels and areas of interest in healthcare on that cruise to
Hmm.
sit around and talk about dialogue, see it from different people's
Hmm.
point of view, and maybe even, come out with some action plans where those individuals can go to their own towns, countries, cities, whatever,
Hmm.
and be able to um, take some action that gets things moving forward. Even just the connections of people across the country and around the world, I think would be very hopeful for nurses, particularly who only see basically what's going on in their 12-hour shift
Yes.
in their particular department, in their particular organization. So
Hmm.
next time you come back, we're going to have all the ideas that maybe can you join us on the
Well, we'll have to
cruise?
see. I have to check my calendar. It sounds
Yes.
it sounds exciting.
April 21st to 26th.
Okay.
Bring people with you. I'm just so excited to be able to have that time to talk to nurses and
Hmm.
other healthcare participants. We're not holding it to nurses. They can bring
Hmm.
their family, their friends, their spouses, their colleagues,
Hmm.
anybody they want to bring, that even just somebody who wants to just have a good time.
Yeah, it sounds great.
Yep. So at that, I'm going to let you go. And thank you so very much for coming today. And maybe May, we'll talk about May.
Okay.
We
All
can
right.
get together again. All right.
Sounds great. Thank you for
Thank
having
you.
me.
Bye bye.
Bye bye.